Hey, welcome back to Overhead Athletics. Max and Chuck here. We're going to go through a 5-part series on UCL tears. Starting with this first video, we're going to talk a little bit about different types of UCL tears. Then we're going to go into the next video where we're going to go into some manual therapy for the UCL tear. We're going to go into some exercise in the subsequent video. We're going to go into some throwing in the video after that. And we're also going to talk a little bit about different surgeries and surgical approaches and recovery times for the UCL. So we have a 5-part series here. We're going to hit all the different aspects of UCL tears. This one specifically, we just want to talk about different types of UCL tears. When we're thinking about the ulnar collateral ligament, we have to think about the stresses that the throwing athlete places on their elbow when they go into the throw, and that's why it's really important to consider the type of tear as well as the extent or magnitude or amount of damage that the UCL has encountered when we really think about prognosis and when we think about getting those athletes back on the field. Talking about different types of UCL tears, I want to think about the anatomy a little bit first, and then we can talk about how we assess that anatomy. And what you're going to do to assess a post-operative thrower who's had a tear and now has had surgery like myself is going to be very different than what you do with the athlete that comes in and you don't know if it's torn. So you have to have an idea of the anatomy in mind. So if we think of this as the athlete's elbow, this is kind of the point of the elbow, the olecranon process. The inside point of the elbow, the medial epicondyle, is here. And we have a bunch of muscles that come in to that medial epicondyle. So all of these forearm flexors, finger flexors, everything that kind of does this, all attaches in here. Now we have one that turns the forearm over this way, the pronator teres, that wraps around to the back of that. So coming here, while all the others come there. So the lower arm sitting right here just like this. Now underneath that, we have a nerve that runs right through this groove here, the ulnar nerve. And then we have the ulnar collateral ligament. So on this model here, it's a little bit difficult to see, but you have the ulnar collateral ligament coming from this bone here and attaching right down to this bone there. The most important component of this ligament is known as the anterior band, or the anterior bundle. The anterior component of the ulnar collateral ligament is always the most important. So the anterior portion, you can kind of see these striated lines, comes down and attaches to a little bump on the bone here known as the sublime tubercle. When it comes detached, we have a torn UCL, and it can become torn at the proximal end where it actually attaches to this medial epicondyle, or it can get detached or torn down at this end, a distal tear, and then we can also have a mid-substance tear where it starts to break down and tear in the middle. The mid-substance tears are generally chronic overuse injuries where athletes have thrown a lot for a long period of time. Our college and professional athletes will often get those forms of tears. If we're going to understand the prognosis of UCL tears, we really want to understand the anatomy just a little bit. Here's the arm. So we have the point on the back of the elbow, known as the olecranon process, the medial epicondyle, this point on the inside of the elbow, and then we have the capsule of the elbow in this elbow model. Think of this elbow being right here. Now we know when the elbow is in this position, where it's about in this range, the most gapping occurs on the inside of the elbow. That's the stress that really damages the ulnar collateral ligament. The ulnar collateral ligament has a posterior component and an anterior component. The anterior bundle and the anterior band of the anterior bundle lie right here, and that's really the component that gets injured in most of our throwing athletes. So we have a line on this model that kind of shows you right here, and then you have a portion of that UCL that comes from here down to there, and that is really the portion that doesn't get so damaged in our throwing athletes and is really stressed more inside 90 degrees. The part that gets torn is stressed more out here. If we look at Chuck's elbow here, we've drawn essentially the UCL. So bone on the inside of the elbow, the medial epicondyle, olecranon process. So we're familiar with the joint there. Now we have the posterior bundle, the anterior bundle, and then there's an anterior band on that anterior bundle that is the most torn. So it kind of goes right here from this bone to this bone. Underneath all of these flexor muscles, all the muscles that flex the fingers, move the fingers, and then we actually have another muscle, the pronator teres, that wraps around back. So we have a lot of muscles that lie in this area. We have the ulnar nerve, the nerve that comes down into the pinky and the ring finger that lay on top of it. But the UCL itself is right here. So when guys tear their UCL, a lot of times they feel a cramp of these muscles because the muscles are trying to stabilize the joint, and a lot of times they'll feel a zinging down their hand because that nerve gets stretched because it's right in that same area. So one more time, this is the component of the UCL that becomes most damaged, and it basically lies right there. It goes from this medial epicondyle bone to a little bump on the ulna known as the sublime tubercle. It can pull off of either end, and it can pull off of the distal attachment known as a distal tear, the proximal attachment off the medial epicondyle known as a proximal tear, or it can tear in the middle, which is really our degeneration type of tear, our tears that happen in our college and professional athletes as a result of cumulative throwing load. Based on the type of tear that you have will determine in some way your prognosis. The larger the tear, if it's a full avulsion or a full thickness tear essentially of that UCL, that's going to be something that likely requires some surgery unless you're trying to play for just one more year, play out your senior year of high school or whatever it may be. If you have a partial tear, it's really going to be determined based on the extent of the tear and the location. What we know now is that proximal tears, so tears where this blue portion tear off up here, they do a little bit better if they tear there than if they tear down here. And the ones that tear down here generally are a little bit easier surgically to do some other approaches like a internal bracing procedure, which we'll talk about a little bit later. So those are essentially the main types of tears. Partial tears, especially in our position players, are something that we can potentially rehabilitate without needing surgery, with altering throwing mechanics, making sure we do the right exercises, and kind of calming down some of those really hot or aggravated, exacerbated tissues. And so that's what we're going to talk about in our manual therapy video. However, our next video in this series, we're going to go through how we assess the UCL, and somebody that's walking in has had a bout of throwing and now has elbow pain. We want to look at the ulnar collateral ligament. What you're going to do to assess those individuals is very different than what you're going to do to assess your individuals who have had surgery already. But remember, partial tears, there's a chance that you can rehabilitate those injuries without surgery, especially if they're those proximal tears tearing off of here, and if those individuals are position players as compared to pitchers. Now that ligament's never going to fully heal back the way it originally was, but we can get some scarring. That ligament can kind of tighten up with a little bit of rest, and that's what we've seen in the research, is that the more you throw, the ligament becomes thicker, which does not necessarily mean the ligament is healthier. Generally, that's a sign of cumulative attenuation or breakdown of the ligament, and it becomes stretched out. As you rest, it shrinks back down, becomes stronger once again, and a little bit tighter. And that's why rest is so important. So just because the ligament is thicker doesn't actually mean it's healthier. So we want to see you guys in the next video. Make sure to subscribe to the channel right now so you don't miss out on how we assess the UCL, how we apply manual therapy, or how you can utilize exercise as well as throwing evaluation and throwing interventions to improve your post-op UCL patients. And if you have a UCL tear where you're not getting surgery, we can utilize many of those exact same techniques and scale them a little bit differently. So subscribe to the channel so you don't miss that. Hit the bell for notifications, and we will see you guys in that assessment video.